Good morning, good afternoon, and good evening from wherever you're facing us from. Really excited to have you here on one of our first webinars in a long time. So, really excited to have you here. My name is Dr. Jemima Kariuki. I'm the founder of Wills for Life. I'm also a gynecologist, and I'm so excited to be here today to discuss something that is really important. We are going to be talking about preeclampsia. So I hope you're all ready. If you're with us, just wave so that I know we are together. And please feel free to comment, like, share. If you're joining us for the first time, down there you'll find a follow button. Please subscribe to the channel, like what you see so that we can keep engaging, and really just so excited to have you here today. So as we start, let me just upload. Please feel free to ask your questions. We are here for you. I have a presentation for you, but I really just want to have more of an engagement kind of. So yeah, please just let's talk. It will be more fun if we talk. Yeah. So there we go. Post, as you can see, we can post together. Karibu sana, Bridget. As usual, thank you for joining us. Happy to be here. So if you're just joining, as I've said, we are going to be talking about preeclampsia. I just want to upload for us the presentation of the day. Just a minute. Going to be just a second. All right. I feel happy to be here. Thank you for all the people I'm seeing joining in. It's such a pleasure. Lives are interesting. I get scared by them. I'm happy with them, but definitely good to be back. So as I add this to stage, preeclampsia. So what is preeclampsia? We were discussing about how can we call it? We were discussing about the week. How do we say it? We were trying to remember preeclampsia and the importance of preeclampsia. There's a week scheduled for it, and I had promised that we would do a session on preeclampsia. And also, it's one of the requests I really found from most of you in the WhatsApp group. If you're new to us, we have a Wills for Life WhatsApp group, one that is free, one that is for subscription. Please join us. We also have an app. It's called Wills for Life. Pause, download. Let's get on there. Yeah. So preeclampsia is a sudden onset of hypertension, okay, that occurs after 20 weeks gestation. Now, if you've been pregnant or you are pregnant, you know that we start counting pregnancy from conception, actually 2 weeks before conception, from your last menstrual period. So hypertension that occurs within the first half, which is the first 20 weeks, we consider that more of a chronic hypertension that had not been known until pregnancy. But if you have a sudden of hypertension that is occurring after 20 weeks, then that is called hypertension of pregnancy. There are different types of hypertension of pregnancy. We have gestational hypertension, which is a less severe form where your BPs are raised. They're not above 160 over 110. They don't have any, they don't affect any end organs, and we are very keen to monitor it, but that's just called gestational hypertension. And then now we have the more severe forms, which is the eclampsia syndrome. So where you have elevated blood pressure. Blood pressure is what we usually measure on the non-dominant side, left or right, depending on where you're dominant. And when we measure that, we find it is consistently above 140 over 90. In severity, it will be over 160 over 100. So remember, there's a top figure and a lower figure. So the top figure would be what we call the systolic pressure. If that is consistently over 160 or even just gets to 160, and the lower figure, which is actually what we fear more, If it's above 100, then we call that severe preeclampsia. And then we have rather preeclampsia with severe features, and then we have now the multi-organ disease. So 1 to 5 out of 100 pregnancies, that's 1 to 5% of the pregnancies, develop preeclampsia, which sounds like a low figure, but it's actually quite high. And it's one of the causes of maternal death, actually. Somehow now becoming even higher than bleeding, because we've really gotten a grasp of bleeding. So that's one. Then we have it gives you multi-organ disease, which means because of how it forms, I'll try to go into the details of how you get preeclampsia. But because of how the placenta forms, it causes blood constriction. That blood constriction will affect the kidneys fast. So we actually say preeclampsia is a development of sudden onset high pressure and protein in your urine. So we call that proteinuria. And you will notice that we are very keen to ask for a urine analysis in each and every OBS-GYN visit. We find it very important because it eliminates for us whether you have UTI, urinary tract infection, that may be asymptomatic. But for today, the importance is if you have proteinuria, which means protein leaking in the kidney. Why that is important is because, and I'm going a bit into pathophysiology, is because the kidney is supposed to retain all the protein in your body. And therefore, if you're having proteinuria, then that means that the kidney is unable to perform its functions. The glomerular filtration is not working as it ought to, and that tells us that there is a problem. Okay, and see a typo there. So preeclampsia is usually mild, but can be severe and life-threatening. Okay. So it's caused by placental abnormality. There's nothing mom can do, there's nothing dad can do. It ideally, when the uterus is rather when the placenta is forming, it penetrates into the lining, the internal lining of the uterus, okay? And then we usually have what we call spiral arteries. These are arteries that feed the lining of the uterus. So as the placenta embeds onto it, it makes the spiral arteries become wider and dilate. So they're supposed to dilate, okay? So that's how it's supposed to work. They're supposed to dilate. So when they fail to dilate, or the penetration is not enough, that it will give you Increta syndrome, or so or this lining, as the spiral arteries are dilating, if they start getting a fibrous tissue around them for reasons that we don't understand, but they become fibrous, then that vessel is unable to expand as well as it ought to, okay? And that causes narrowing. That narrowing is what brings about preeclampsia, which in effect is very elevated pressures around the placental unit. Remember, the placental unit is made up of mom and baby. Okay, so that is where all the exchange happens between the mom and the baby. So when you find that you have a thinned out or narrow arteriole, then the pressure increases. It's like when you finya a pipe, for lack of a better word. So when you compress a pipe, then you increase the pressure. Okay, so that pressure backlogs and goes into the rest of the body, especially for the mother. And for the baby, you can see how it will cause restricted growth in the baby, because there's narrowing, there's less time and less space or surface area for the baby to exchange the nutrients that they want and give out, or rather excrete throw out what the fetus does not want. Okay, so that will give you some of the features that we see: a smaller baby, that is fetal growth restriction, reduced fluid, oligohydramnios, because there's less fluid or less time or surface area to exchange this. Okay, so it has detrimental things to the mother and to the baby. So I'll go to the baby because that's the pathophysiology. Okay. So the baby, I've explained fetal growth restriction. They may end up with reduced fluid in the sac, amniotic sac. Sometimes it can even lead to death, especially if the pressure is very high, then it's dropped very suddenly, then you can get sudden fetal death. Okay, especially around that 33, 37 week mark. For some patients or for some babies, they can even end up having placenta abruptio, where the placenta detaches before the baby is born. I did a feature on placenta abruptio. I'll make it a discussion as well. So that's for the baby. For the mother, there's increased blood pressure circulating around the entire body. Then there are those hormones that are being released by the mother, sorry, by the fetus and the mother to support the pregnancy. Okay. So one of the things that happens when you have consistently elevated blood pressure is that you start getting shunting. So the kidney is the one that is fast hit. Okay, so when the kidney is hit, you end up having destruction or damage to the glomerulus. Glomerulus is the single most important unit of the kidney. It's what filters everything that passes through the kidney. So that one is the first that will be hit, and we will notice it because you will start releasing protein. Okay, proteinuria. So when you have proteinuria 3 plus, then you'll have a problem. Okay, just a minute, go back. You okay? Come, sweetie. Just a minute. Apologies for that. Yeah, so I was explaining about the pathophysiology of of preeclampsia. Apologies for that, working from home. Yeah, so I was explaining about the pathophysiology or the pathophysiology of preeclampsia. So, number one, preeclampsia is known to have, I've talked about the kidney issues, and that will give you the proteinuria. The second thing that people get is a severe headache, and that's because of the increased pressure on the head. Okay, so that's the second thing that you need to look out for. And then the other thing that you need to look out for is the epigastric pain. I'm going to the symptoms, and I want you to understand why you get these symptoms. So, the other thing that the preeclampsia affects is actually the liver. Okay, so it actually affects the liver, and the one thing that you will find is that it it makes the liver's enzymes to swell up. So one of the things that we keep monitoring is actually the liver enzymes. When the liver is affected, it elevates. It also increases the pressure within the liver. And within the liver, we have something we call the capsule, or what covers or encases the liver. Okay, so the liver is covered or encased by a capsule. So if there's increased pressure within the liver, then the capsule will start responding to it as pressure, and pressure in the visceral organs or internal organs is demonstrated as pain. And that pain will be felt at the epigastrum, which will feel like a heartburn, a very bad heartburn. Now, even when you take antacids, it's not working. So that's the other thing. And then the last and most important is that if it goes to your brain, then increases the pressure, you can get a seizure. So when you get a seizure, that is called eclampsia. And eclampsia demands immediate delivery. Okay? Demands immediate delivery. It can cause a bleed in the head, and that can actually give you features of a stroke. Okay. The other thing that you'll see is that because of the increased pressure, there's small micro vessels, those tiny two vessels, used to call them capillaries. They can start bleeding. So when they bleed, the platelets go to respond. As that consistently happens, then you get hemolysis from the red blood cells, which just means you keep bleeding, and then the platelets will keep responding. So that hemolysis and the platelets responding means your platelets will reduce. So that's one of the things that worry us, because it means that you're unable to clot sufficiently. So I hope that explains these symptoms. The severe headache that doesn't go away. Yeah, so the severe headaches that doesn't go away. Problems with your eyesight also affects the eye, can give you glaucoma or scotoma, not glaucoma, scotoma, which is like a flashing in front of your eyes. So that it seems like there's a kauchafu, like that on one area or a blood area on one side. That's a scotoma or a blood vision. Okay. And also gives you severe pain below the ribs, which I was trying to explain, the heartburn. And then there's the swelling. Most people recognize elevated blood pressure by swelling, but this swelling is not only on the hands, not only on the feet, which is normal in pregnancy, due to positional or postural edema, swelling because you've sat down the whole day or you've walked a long distance. But this is swelling on the face, swelling on the hands, and then, of course, the feet. Okay. And that swelling is rather rapid. So that's one of the symptoms. But for most people, you will not know. You may go for your regular clinic, and then you go and you find that during the regular clinic, they find that your pressure is high. Okay. So if that be the case, then you'll need to be monitored closely. They'll check your urine. If the urine is also having proteinuria, then they may end up giving you medication. Okay. Right, so preeclampsia can happen in any pregnancy, but you're at a high risk if your blood pressure was high before you became pregnant, your blood pressure was high in a previous pregnancy, you have a medical problem such as kidney disease or conditions affecting your immune system such as lupus, rheumatoid arthritis, and the rest. If you have type 1 or type 2 diabetes, and in all this we suggest that you take aspirin in your first trimester, after your first trimester, from 12 weeks to 36 weeks going forward. Okay, then other side effects. Oh, sorry, glitch. Other side effects that are common and that you will see is other risk factors that you will find if it's your first pregnancy, which we call a primigravida, if you're an elderly primigravida, or if you're pregnant over the age of 40, if your last pregnancy was more than 10 years ago, if you're overweight or obese, if you have a relative, especially a mother or a sister, who had preeclampsia during her pregnancy, if you're carrying more than one baby, if you have any of these symptoms, like, let me repeat: first pregnancy, 40 or over, last pregnancy was more than 10 years ago, you are overweight, or your BMI is higher than 35, if you have a first relative, especially your mother or your sister, who had a history of hypertension in their pregnancy, then you are at risk of getting preeclampsia or hypertension of pregnancy. And therefore, you need to be on aspirin from 12 weeks until 36 weeks. Okay. How do we monitor pressure? Baba sawa. Tutachukua ingine. Kwa duka, acha nimalize baba. Okay. I'll come. Go watch TV. So how do we monitor preeclampsia of pregnancy? Number one, if it is very severe, the pressures above 160 over 100, I've seen pressures over 220 over 135. That's a direct admission. Why? Because we need to slowly bring down the pressure. If we bring it down too fast, we risk losing the baby. If we keep it up there, then we risk you getting an eclamptic fit or something worse, bleeding into the spleen and bleeding into the liver and all that. But mostly we are scared of you getting a bleed into your brain or eclampsia. Okay, so we need to closely monitor how the pressures are going. We need to look at the rest of your organs. Is your kidney fine? Is your liver okay? Are your vessels okay? So those are step-by-step labs that we'll do as you're admitted. Okay. If it's not as severe, we'll continue monitoring outpatient. Depending on severity, there are those we do regular monitoring daily, and then there are those who we step down slowly. Okay. Then there are blood pressure medications that we recommend based on your severity. Again, some people on one drug, some are on three, and then depending on how you will be responding, we'll give you medications as such. Okay. And then there's a scan. We do a scan every 2 weeks just to make sure that the baby is growing normally. In some cases, we'll do 4 weeks, depending again on the severity. So how do we manage it? The management for a preeclampsia syndrome is delivery. Other than that, we are just buying you time to get to when the baby is fully developed, or at least 37 weeks. So in the cases of severe preeclampsia, you'll need a specialist team. Sometimes you need a multidisciplinary team. You may need to be taken to in a high dependency unit, especially if you're bringing down medication using using the IV labetalol and what have you, or hydralazine, because they can really drop that blood pressure, which is not good. Okay, then we give you magnesium sulfate for 24 hours. This is to prevent you from getting a eclampsia or a seizure attack, or to control the seizure if you have the seizure. If you have magnesium toxicity or there's a problem, you will check. We'll be looking at your reflexes, and then we will exchange the drug. Okay. Delivery is very important. If you get elevated pressures after 37 weeks, we're likely to ask you to deliver or to guide you that we deliver earlier. If it's below 37 weeks, we are likely to extend time until when we know that the baby can make it, and then we deliver. If it happens too early or we see that mother is at risk, we'll also advise you accordingly. And then, of course, we make the decision together, but we will stress upon the need for early delivery if we note that it is bringing issues to you. Okay. So what happens after delivery? Hypertension usually goes away, preeclampsia itself goes away. That those who get elevated pressure or hypertension after delivery, if you had it before we started the delivery process, you may stay in hospital longer as we monitor. Or if there are other issues that happen, for example, kidney failure or liver issues that we need to take care of. If your baby has been delivered early, they may need ICU care or NICU care, but that doesn't mean you can't breastfeed. If you're taking medications, you can you can easily express the milk and baby will be given, and that's okay. All right. We will closely follow you up, sometimes weekly, sometimes 2 weekly, as we titrate the drugs downwards until we notice that you are okay without the drugs. This can happen between 6, sometimes even up to 12 weeks when you're still titrating the drugs downwards. Okay. So recurrence really depends on when you got the preeclampsia and how severe was it. So for example, 1 in 3 women get preeclampsia if the baby needed to be born between 28 and 34 weeks of pregnancy. 1 in 4, that's 25%, will get a recurrence if the baby was born between 34 and 37 weeks. 1 in 6 women will get preeclampsia in a future pregnancy if their baby was born after 37 weeks. So the later you deliver your baby, the better your chances or the less your chances of a recurrence, which is a good thing. If you have gotten preeclampsia before, then you are likely or more likely to develop high blood pressure in future, including the issues of stroke and heart disease in later life. Therefore, you need to avoid smoking, maintain a healthy lifestyle, maintain a healthy weight, avoid salt, have a high protein diet. This is also in pregnancy, and really work together with your physician and your gynecologist. So that's what I had in terms of today. So the keynotes: it affects 5% of the women, diagnosed after 20 weeks. The signs of preeclampsia include high blood pressure, protein in urine, that's proteinuria. It can complicate for you and your baby. There's mild preeclampsia, and then of course there's a severe one, which is what we are really worried about. We will control the pressure with medication, usually oral, unless there's need to go into IV medication. If you have preeclampsia, you're at risk of developing high pressure later on in life, and therefore you need to safeguard yourself. Now, the source of all this is from an ARCOG guideline. You can download it. It has all this information, or you can always come back and rewatch for future use. So that's what I had in terms of presentation. So now we can open up for live discussion. So any questions, I'm free to answer. As I wait for your questions, how often do I see preeclampsia? It's quite often. As I've said, 5% of the population, but it's more often than we can see. And usually it will let you know. You may start with a pressure of 137. It's not 140, but it's not 120. It's going 137, 138. The lower one is 88, 89, and what have you. So when we say that, you'll notice that we'll really closely monitor the pressure. The other thing is, if you have risk of hypertension, then we put you on aspirin. The message today is that aspirin really helps. Aspirin helps when with junior aspirin, though, not the regular aspirin. Junior aspirin, we call it Ascad. So junior aspirin really helps. It helps with reduction of miscarriages, and here it helps with reduction of chances to get preeclampsia eclampsia syndrome. So we start you at 12 weeks all the way to 36 weeks. And then we stop it because we don't want you to bleed excessively during delivery. It's a blood thinner. The other thing that we'll advocate for is calcium. Calcium supplements are very good, or they've been seen to actually improve or lower the effect of hypertension on the pregnancy, especially on the baby. The other things are arginine. L-arginine has also been seen to really help with the baby and the pregnancy outcome all through. So those are the things that we can say really help. If you've already been diagnosed with preeclampsia, we'll suggest that you reduce your salt intake, exercise regularly, even within the pregnancy, take your medications. I've seen that most women get scared of starting pressure medication because you don't want it to be lifelong. You'd rather be on it, especially during the pregnancy, because it's a disease of pregnancy. After the pregnancy, within the first 12 weeks, ideally it goes away. Okay, so just really need to put that out there that once you start pressure medications, it doesn't mean you have to be on them for life, and it's really key for you to be on it during the pregnancy to control the pressures, especially for you and for the sake of your baby. Okay. And then the last thing that I've seen often is many will say, but it's my third pregnancy, I didn't have it, especially those who are above 38. It's not a disease that you could prevent really, because it depends on how the placenta attaches. However, and to answer this question, is it likely for a mother to not have preeclampsia on her first pregnancy and have it on her second and third? Yes, it is likely for that to happen, especially if you space the children quite a bit. One of the risks was greater than 10 years between the birth spacing. The other thing is the advance in age, because the vessels grow weaker due to age, and then now pregnancy can give you the preeclampsia of pregnancy. Okay, so it's actually quite possible. All right. So I hope you've learned a thing or two. I can't see any further questions. So happy you joined us today. We were discussing preeclampsia in pregnancy. It has many other effects, the placenta, braccio, and what have you, that we will discuss in a subsequent discussion. And then we'll see. Oh, I can see questions. I've been having pressure, hands, both hands. It's like I lose strength on both hands that lasts for about 5 minutes, then go away. If countering something, it drops. Can it be a cause of pressure? This looks like something else. It looks like tendon. It's called what? Tachinovirus. It's an affectation of this tendon here, and it is an effect of pregnancy, yes, but it's a pregnancy effect on the cartilage or the nerve here. Actually, it's a cartilage more of. So you need to just put pressure on it, or just have a pressure compression. What is it called? something that will compress that hand and elevate it. Yeah, so we have this really nice hand supports that can help with that, especially within the first 12 weeks when you're recovering postpartum, and you'll start noticing it at the later trimesters of pregnancy. So it's common. The word is hard, it's tendon desiquinovarus, something like that, but it is there. Physiotherapy will help, and just support, hand support, and that should go away with time. But no, it's not a symptom of high blood pressure. No. Yeah. So thank you, Lydia, for that question. Really happy. Great. So there being no other question, I just want to say thank you. God bless you. We meet again next Wednesday, not Thursday, next Wednesday at 8 p.m. for our next lesson. If you have any questions, do let us know. We'll respond accordingly. And if you haven't hit subscribe, please subscribe. Please subscribe. It goes a long way. Like, share the channel. We also have an app, Wills for Life, is on Play Store. Please download the app, and we'll chat there, move all our chats there very soon. So I hope to talk to you. I hope to communicate with you. I hope to chat with you. Bridget is on the comment section. She can add you to a group if you want to be a part of our WhatsApp channel. I'll also put our number 0719 116611, so that if you need to join the WhatsApp channel, please let us know. But we are really happy to know you, really happy to serve you, and God bless you. Thank you so much. God bless you too, Bridget.